Hello and welcome to the webinar, Journey to Baby Friendly, Lessons Learned from the EmPower National Collaborative, St. Vincent Women's Hospital. We want to thank our sponsors, Indiana WIC and St. Vincent Health. As part of the EmPower Breastfeeding Collaborative, St. Vincent Women's Health will become a baby-friendly hospital in 2017. The EmPower initiative is a CDC-funded program that offers hospitals resources and support in navigating their journey to becoming baby-friendly. Becoming a baby-friendly hospital is challenging and rewarding, as all maternity care processes need to support the 10 steps to successful breastfeeding. Kat Tatum, Amy Lane, and Jill Lancaster will share their experiences and insight in this exciting change for St. Vincent.
Thank you, everyone, for joining us today. Kat, Amy, and myself, Jill Lancaster, are going to walk through our relationship that we've been in with the EmPower Collaborative. And to start out, we're going to talk a little bit about what EmPower is. EmPower is an organization and a collaborative group that is promoting and enhancing maternity practices and breastfeeding throughout the country. It's an initiative that was funded by the Center for Disease Control and Prevention's Division of Nutrition, Physical Activity, and Obesity. And it was created to support hospital-based quality improvement, focusing on maternity practices that help lead to Baby-Friendly USA designation. With the EmPower initiative, EmPower is really based upon the Baby-Friendly Hospital Initiative guidelines and evaluation criteria for facilities seeking baby-friendly designation. We follow the same 10 steps with the baby-friendly hospital initiatives as everyone else, and we have coaches that help us along the way. So participating hospitals receive technical assistance and coaching from breastfeeding and quality improvement experts to help us implement those steps and work towards destination. Each facility within the collaborative gets one breastfeeding coach, and one quality and improvement coach is assigned to us too. The EmPower initiative is led by ABT Associates Incorporated, which serves as a partner with the Carolina Global Breastfeeding Institute and the Center for Public Health Quality. To lead the EmPower initiative, provide overall program management and infrastructure, and conduct the evaluation activities. The core partners in the initiative, again, are the Carolina Global Breastfeeding Institute, and they serve as the breastfeeding experts and lead recruitment efforts for the initiative, so helping to bring people into the initiative. Center for Public Health Quality, they serve as the QI, or the Quality Improvement Experts for the initiative. They help lead the development of the Hospital Action Planning Guide, and they monitor all of our quality improvement measures as we have been going through the process. Baby Friendly USA also provides training specifically to the EmPower technical staff, and then they provide guidance throughout the designation process to us too, kind of fast-tracking us through the process. How did we become a part of the EmPower initiative? There was an application process that we applied, as well as multiple other facilities throughout the country. One other facility here in Indiana also applied and was accepted, and that's St. Joseph Health System in Plymouth, Indiana. The two groups that were selected, the collaborative was looking for, and the initiative was looking for, hospitals that had a multicultural basis with a diverse financial population of patients, from insured to Medicaid, looking for that large kind of education groups down to small, more rural hospital groups. And as a selected hospital into the initiative, we receive ongoing tailored technical assistance to move us more quickly or advance our journey to becoming baby-friendly USA designation. And then we have our payments for D3 and D4 are actually paid through the EmPower initiative. We also receive some educational support through LER or the lactation education services or an equivalent training vendor up to the amount of $3,000. Current hospitals that are in our collaborative group are highlighted on the map. As you can see, in Indiana, there are 2 of us. Most of them are on the eastern portion of the United States. In our specific cohort, we have some hospitals from California that are going through the initiative with us also. Our coaches here at St. Vincent are Julia Borg. She is a nurse, IBCLC, and has become a breastfeeding coach for EmPower. She originally started her journey as a lactation consultant working in a hospital in Louisiana and went on to lead her hospital in the Baby Friendly initiative. Luann Crawley-Stout is our lean improvement specialist or quality improvement coach. Luann currently resides in North Carolina and works with quality improvement projects across the nation. She is actually a former associate here from St. Vincent in our quality department, so she has been really helpful in knowing our processes and pieces here at St. Vincent. When it came to staff education, we've really sat back and looked at what the best platforms for our staff was for education. We have a very large staff that we're looking at trying to educate, and for those that are unfamiliar with Baby Friendly, we have 15 hours of didactic coursework as well as 5 hours of hands-on for our maternity nurses. And our physicians need 3 hours of didactic Baby Friendly education. So as we were looking through it, we decided that Cofective was really the best platform and most interactive of the ones that were out there for our staff, and so we have elected to do that. We will be paying for our own staff education and using our money from the EmPower grant to pay for our physicians to be trained through the LER program. LER is one of the only providers that does the physician online education component for us. And then we'll be working here at the hospital on our 5 hours of hands-on and skilled stairs. The 10 steps to successful breastfeeding. In the collaborative and as a group, we've gone through and we did a quality improvement project. When our coaches first came for their very first on-site visit, we sat down and we looked at each of the steps and the details under each step to highlight out where we were as an organization from a quality improvement standpoint of where are we today and where do we need to be in the next 18 months to become Baby Friendly designated. And as we did that, we highlighted areas for improvement, and we also found successes where we had already been met those components. Currently, we have completed our development phase, and we are moving into the dissemination phase. As those that are familiar with Baby Friendly, you really kind of flow from one into another, and you're already working on dissemination while you're completing your development phase. So data collection will become a big piece for us as we move into dissemination and following the Baby Friendly USA collection plans. As part of EmPower, we have data collection points that we already have been tracking. So pieces within our quality improvement as being part of the collaborative, we run PDSA cycles, we do monthly mom surveys, and we do monthly chart audits. And I'm going to let Kat talk a little bit about some of the PDSAs that we have completed on the postpartum newborn care unit.
So when we first met to discuss some of our perceived gaps, one of them was our challenges with having the baby's room in the rooms with the moms for 24 hours a day. So one of the very first PDSAs we did, we asked for some volunteers from the staff who were supporters of the Baby Friendly process, early adapters, and we had lots of volunteers, and what we asked them to do was to take a couplet in their assignment and just really encourage that couplet to stay in the room 24 hours a day. And we wanted to look at the things that were going to be challenging for the staff, and that would be testing, hearing screen testing, newborn screen testing, weights in the rooms, things that we have traditionally not in our hospital done in the baby's room. And then we had a survey afterwards also for the parents to see what their experiences were. And we did have some criteria. We narrowed it down to people who delivered vaginally their first baby, because we wanted people who hadn't had experiences with putting previous babies into the nursery before. So the feedback was from the patients was fantastic. They really liked it. We had really high success rates of people keeping their babies in their rooms with them their entire stay. I think the only times one of them went to the nursery to be seen by a pediatrician briefly and for circumcision, and that was it. We didn't manage to do everything else in the room. So that was a big win for us. The staff feedback was great. They did like it too, but we were able to illuminate some challenges that we had just with our workflow, and those are the things that you hope to have come out of a PDSA. So we know that the things that we need to work on, which are, getting scales into the room, and a process for weighing the babies in the rooms, and a process for doing hearings.
The broadcast is now starting. All attendees are in listen-only mode.
So that was one of the PDSA cycles that we did.
And then the monthly mom and surveys and chart audits. I'll let Amy speak to.
So almost a year now we've been doing monthly mom surveys. We pass out 30 of these a month randomly to moms on the floor. They need to be healthy moms and babies. So if a mom if the baby has been in the NICU, we don't give that mom a survey. And we've had some pretty good comments and feedbacks from moms on the survey. And we're also doing 30 chart audits a month, random as well, on healthy moms and babies. So this has given us a good baseline from where we started, and we'll be able to see growth and improvement as we make the changes in our the way we do things. So it's been a big help.
So one of the tools that we have access to as being part of this EmPower collaborative is what's called the EmPower platform. And within that EmPower platform, there are breastfeeding resources, quality improvement resources, some project management and team building resources, and then we have monthly updates and biannual newsletters that get put out onto the platform. It's also the place that we go to submit our monthly audits and surveys. So for us, our electronic health record is unfortunately not able to download our chart audit information directly into it. Some of the facilities within our collaborative can just dump that data straight into it, and then they get nice, tidy reports back from EmPower. We have to, unfortunately, do some manual entry of that, and Amy spends usually a couple hours a month taking the paper data and then putting it into the computer, and we can pull graphs to see where our successes are, where we need to continue to work. And then the great thing is our coaches and our quality improvement coach will review it and say, hey, have you looked at your trending and how you're doing with pacifier education or exclusive breastfeeding education. There's also a great portion with the community forum. On the community forum, it's a place that we can go out and post a question to all of our other collaborative partners. And there will be different pieces. If you have a great handout that's been created, then we can put it out on the forum and others can take it, and it's a share and take kind of site, so that if you create something, put it out there so that everybody may be able to build off of that, and we're all doing this for the babies and for the moms. So it's not a competitive thing. And it's a great place to ask questions when, hey, how do you do this? If one of the slides, or on the picture on the slide here is, do you have an intermediate nursery? That's one for us that has been a challenge, as we have a continuing care level nursery, and are they in scope or out of scope? And we've had some really good conversations with our peers about what that looks like. Our coaches do site visits. They do a site visit initially, so they came here before we actually had even put our application into Baby Friendly USA. They came, we did a large gap analysis as we were talking about going through the steps for Baby Friendly and determining where our big gaps were and where we needed to start with our process of looking at improvement. They review our quality indicator procedures, make sure that we understand how to do a PDSA cycle, how to do a run chart, look at data and be able to pull out what we needed to do with it. They reviewed our EmPink survey data with us and from our previous EmPink and talked about how we saw ourselves already improving upon those scores, but where were the focus areas from that we needed to work on. And then they helped us fill out our Baby Friendly USA facility data sheet and the self-appraisal tool. Developing a hospital planning guide is another big piece with us, and we did that as a multidisciplinary team. The one thing that EmPower has really pushed is that we need to have a multidisciplinary team to look at this approach. And our multidisciplinary team is made up of our executive leadership, including our CNO and CEO, nursing directors, nursing executive directors, unit directors and managers, our neonatologists, we have a pediatrician, an obstetrician, physician leader that all sit on that group, pharmacy director. We have someone from our informatics department so that we have the technical support for our computer documentation right there at the table. A quality liaison is there, our dietitians, lactation consultants, bedside nurse representatives, chaplains, and social workers, as we all have to work on this together as a team. Then we have state group calls, and the state group calls are monthly. They're pre-scheduled. It is an expectation that we will attend the state group calls, or someone from our organization will be represented on the state phone call. Those are facilitated by our coaches. It typically rotates back and forth between our quality improvement coach and Julia, our baby-friendly coach. They facilitate the conversation. During those, we typically review one big content piece, and then we have roll call of what have we done successfully, and then what questions do we have, what can we team share on. Our little group is composed of Indiana, Kentucky, Ohio, and West Virginia hospitals. And then each month, like it said, we do focus on one of the 10 steps to review criteria also. Great thing that we've really found the most value in at times has been the webinars that have been shared that we have access to. They are computer-based, and if you're not able to attend or it's a great webinar, we're able to share it with all of our staff and have them review the webinar content. One that just came out that we're excited to have and we want to share with our pediatricians and have conversations with them about, as we've heard recent concern over safety and baby-friendly and the balance of safe sleep and all of those components is the balancing breastfeeding and newborn safety. Others that have been on there are monitoring and measuring data collection, understanding your own data so we can learn how to really pull from our data and find ways to use that to our benefit. And then progressing through the 4D pathway, what steps can you work on things concurrently? What does that look like? And then most recently, they just did this dissemination into designation phase, as a lot of the facilities were slightly ahead of us when they got started and are getting ready for designation. Another big piece of being part of the EmPower Collaborative has been that we went to a yearly 2-day meeting called the Learning Collaborative meeting, and ours, there were 2 of them within the United States. Our group met in Baltimore, Maryland, and the other group met in Atlanta, Georgia the week before us. During that meeting, it's really, the objectives of it are to foster collaborative learning amongst the facilities, provide breastfeeding technical assistance, provide quality improvement technical assistance, and motivate and inspire. And Amy, Kat, and I all attended together in May. We found great benefit. I know that all 3 of us walked back from that meeting and felt energized and excited about why we were on this journey and the outcome of this journey, and seeing others who are struggling with the same things as we are or have overcome difficulties that we've met. The expert speakers were excellent. We had opportunities to sit down in roundtable discussions with other hospitals and talk about step 3, step 4, what our issues and concerns were with an expert on that step. We also had an opportunity at roundtable discussions that sit down with Baby Friendly USA assessors and ask very poignant questions about what does this mean and what are you looking for, which is not something that typically is an opportunity that is had. Other things that we found that were a benefit were we actually met some other Ascension hospitals, who is our parent company for St. Vincent Health, that are going through this process too. So we've made some connections and have resources that we can talk amongst ourselves about what does this look like for our system as we move forward. One of the speakers at the collaborative meeting that we all really, really enjoyed was Dr. Barbara Phillips. She came from Boston University School of Medicine and Boston Medical, and she helped lead the baby-friendly initiative at Boston Medical. And as she came out on stage, she was smoking a cigarette, and all of us were dumbfounded that this woman is standing up in front of us in a hotel smoking a cigarette. And she said, "It's just what we did," and referred to it as, we've always put babies in a nursery. We've always lined them up. We've always done the weights in the nursery. It's just what we did. And it was a nurse that she worked with that used that statement all the time. And she talked about the challenge of change. Why don't we change and how we change? And she was just really powerful in that simple statement of a woman who doesn't smoke standing up in front of us and doing something that was socially not acceptable at this point, and really drilled home why we're on this journey. The EmPower team, we actually got a picture. It was just prior to
the ban, the WHO code, following the WHO code. That was May 22nd, was it last year? So it was, they kind of took a picture and put that out on Twitter, talking about, trying to make sure the WHO code is followed, and support the WHO code, and let the people know that are not following the WHO code that they are not.
And the picture really shows all of the coaches and quality improvement coaches throughout the nation that are part of the EmPower Collaborative. So what have we accomplished here at St. Vincent? We are starting D3, our dissemination phase. We have banned the bags as of April 2015, which was just in prior to us becoming part of the EmPower Collaborative. We have initiated a Wait Till 8 delayed bathing program, which has been highly successful. Lactation has been super excited to see these babies have their baths delayed. We're getting a lot of first few feedings in, good established feedings before the baby's getting that sleepy bath time. Uninterrupted skin-to-skin for 1 hour following birth. Our labor room has really joined, and the leadership there after our original meeting with our coaches really took that as, these are quality initiatives that we need to work on. And so skin-to-skin started out as just initiation with the healthy vaginal delivery patient and just initiation. And now it is the uninterrupted skin-to-skin for 1 hour. We have a 92% uninterrupted skin-to-skin for 1 hour following birth for the healthy vaginal delivery patient. And now they're starting to work on it for our C-section patients as soon as they hit the PACU. New infant feeding policy. We reviewed our infant feeding policies and realized that we had lots of policies that have infant feeding pieces kind of entwined into them, and had to go through and really clean those up and see what they say. Looking at cup feeding and spoon feeding, alternative feeding methods that have just not ever really been a standard because it's the way we've always done it kind of around here. So we've worked on bringing those pieces in and talking with our staff and starting to make them comfortable with alternative feeding methods and looking at that our policies support those. We've developed a series of new prenatal breastfeeding materials. One thing that we did is we took a trip down to St. Mary's, one of our St. Vincent Health partners that had just recently become baby friendly. And when we did that, we took some nurses from our labor and delivery unit, our postpartum newborn nursery areas, lactation consultants. So we made sure that when we were picking the people to take with us, that we didn't take those that were completely baby friendly on board. We found those that were on the fence, or maybe just writing the fence on the negative that, oh, this will never work, it's going to cause more work, I don't know why they're doing it. And we took them on a 2-day trip, and it was a great experience. Those that came back all came back excited. They got to go with staff on the floor and follow them as they did their work, talk to moms. Being in a baby-friendly hospital, can see that this wasn't more work, it was different work, as the nurses from St. Mary's shared, but it was work that was capable or able to be done and actually made some of the processes easier along the way. One of the things we took away from that, though, were those prenatal breastfeeding materials. They had created great touch point materials to be used in the physician's offices, talking to moms during their prenatal visits about breastfeeding. And so they shared those with us, and we've been able to take those and make those work for our whole health system. Rooming in, as Kat talked about before, we trialed that with the PDSA and found that people found ways that it can work. We found some hiccups along the way, ophthalmoscopes and otoscopes for our physicians in the rooms, not having enough, or scales. We probably don't have enough scales to be able to do all the weights in the room. So looking at those pieces, but it really opened our eyes to it is doable. It's just a matter of us having to go through and figure out what pieces we need to put into place. One of the most recent things that we've instituted is lullaby time, which we also learned from our friends at St. Mary's, and I'm going to let Kat talk a little bit about that.
One of the comments that patients frequently make is about how many interruptions there are, people coming in and out of their room, multidisciplinary people, just a variety of interruptions, and how it affects, their ability to rest and their ability to bond with their baby. So one of the things that we decided that we would like to try, St. Mary's had already been doing it, is the lullaby time. And what that means is that from 2 till 4 each afternoon, we let the patients rest in their rooms with their babies, and we don't go in there unless the patient calls out for us or there's something urgent. We delay all routine care during that time. Nobody from housekeeping enters the room, nobody from social services or the chaplains, all of the departments in the hospital. We sent them letters, and they were all on board with having this time. And it's been, the feedback from the patients has been just outstanding. They're so grateful just to have some quiet time. And one of the things we did was make hangers to put on their doors that is a visual cue to remind people coming onto the unit that the patient is resting. So during the lullaby time, we hang them outside each patient's door, and they simply state that the mom and the baby are resting. We ask that we don't have visitors to the unit during that time. The patient's prearranged for someone to come and see them, that's fine. We do allow that. We just ask them to be quiet. If the baby is in the NICU, because we do have a large NICU population, we really allow the nurse, the mom's nurse, to sort of tailor how that time would be best spent for that mom. That mom's been at the baby's bedside just hour after hour and really needs a rest, and we encourage them to come back to their room during that time and have a nap. If the mom has been in the room with visitors and busy and hasn't been able to get to the bedside much, we encourage them to go to the bedside and spend some time bonding with their baby. So it's really given us the ability to personalize how that time is spent for the NICU moms. So feedback from the patients has been excellent. They're so grateful. They have mentioned that they look forward to that time of day because they know it's just going to be time to shut down and unwind. A time where they have a reason to say, can the visitors come later, things like that. It's just really been very positive. Nursing staff likes it too. So it's really been a big win for everybody involved. And it really is helping to get us to that consistent 24-hour-a-day rooming in and seeing that the benefits that can come out of it, even in a short 2-hour span. I mean, we've spread it out over the whole day. We're really looking at some great long-term benefits. So that's been an excellent new thing that we've just rolled out recently.
Pieces of what we have learned along the way. Changing a hospital's breastfeeding culture takes time. We went into this thinking that, yep, we're going to just bust right through this, and by March of 2017, we're going to be ready to sit for our baby-friendly designation. What we've learned is that it takes a little bit of time to change those pieces, and some of those things were easier than we expected, and others have been a little bit more difficult. And as we've done that, we've learned that we need to maybe adjust that time frame slightly by years, but maybe by a few months, allowing ourselves some grace on where we are and how far we've come in a short period of time. We've also really learned that the 10 steps are tools for inclusion. They should be applied to all moms. We've really learned, and I know I've highlighted that below too, that we historically have done a poor job of educating and teaching safe bottle feeding to those who choose to bottle feed their infants. That's an area that we really drilled home as one of the first touch points with our staff as we went into this journey. The naysayers on the units are like, it's all just about the breastfeeding mom. This is just about breastfeeding. It's not about anything else. And we've really made it about, this is about being friendly for families and for babies. And so one of the things that we learned at our collaborative when we went out to our meeting in Baltimore was a really smart woman from the East Coast said, you need to educate, document, and honor the mother's choice. This isn't about forcing somebody to do something they don't want to do, but it's making sure that we make that playing field equal for all families, so that the mom who maybe has never thought of breastfeeding as an option because she just didn't know about it, she comes from an area or a cultural area where breastfeeding hasn't been the priority, or no one in her family has ever breastfed, so why would she ever consider it? Can we make sure that they're educated and understand the benefits for their baby? If they tell us that that's not what their choice is, then we need to step back and we need to educate them on appropriate formula feeding, not just open the bottle, shake it up, make sure you use it within an hour, which I would say for here has been a historically our amount of education we've provided. What is your safe water supply for home? How is safe formula handling with powders, liquids, concentrates? How do you prepare those? And making sure moms understand that skin-to-skin is even more important for the bottle-fed baby because they don't get that skin-to-skin time. So we really drilled that home with our staff to say, this is really about all babies. And it got some buy-in from our staff who then came back and said, I don't know how to safely prepare formula. And so that was another PDSA that we ran and some education that we did right away. Always celebrate the wins. That's a big one that our coaches have been. Each time you get a win, whether it's something small, something big, make sure you celebrate it. For us, it's really been partnering with our hospital-affiliated clinics and physician offices and celebrating the wins that you guys got rid of that formula giveaway bag that was out in the lobby. You no longer have the Enfamil coupon laying down on the side of the table that I found, celebrating those little pieces so that they see that they're doing a good job. At the unit level, celebrating when we had our skin-to-skin get over 80% in the labor room. We celebrated with cookies and things like that. It doesn't always have to be something big. Other things we've learned is to collaborate and partner with our physician offices. Our OB offices have been really open and excited to learn. They didn't understand why having a formula giveaway bag in the office was a challenge, or giving a mom a free bag. It was just something that they wanted to do to make their families feel cared for and loved, and talking about how that can, really potentially cause trouble with breastfeeding, but more importantly, it makes them become a marketing agent for a formula company. Really has helped. While we would like, another big statement we have found that we have really kind of liked is that while we would like for our moms to exclusively breastfeed their infants for 6 months, we aren't asking them to commit to exclusively breastfeeding for that long. We're asking them to exclusively breastfeed their babies for 48 to 72 hours. That actually came from one of the Baby Friendly USA assessors while we were out in Baltimore. She told us that while everybody thinks that this is about exclusively breastfeeding for long term, really it's about establishing a good breastfeeding relationship prior to leaving the hospital. And we're just asking them to commit to this for that time period. And that has helped some of our staff understand that we know that they may do something else when they go home. We want to make sure that they're well educated on their decisions, and that we're trying to get these moms and babies breastfeeding for as long as we can. Working in a collaborative has allowed us to share and use resources and best practices with a large group of care providers. Sometimes we're the group providing that information and how we've gotten over a hill or this big roadblock that we found. Other times it's us reaching out and finding that from a small rural facility who had some great idea that we couldn't even see, even though maybe it was right in front of our faces. Amy, Kat, do you guys have anything that you would like to add that we've learned?
No, I just think it's great to be able to sit down with other hospitals and say, you know, we're having this problem, and for someone to say, oh, we had that problem, this is the solution that we use, try this or try that, because sometimes when you're stuck in your own silo in your own hospital, the problems seem like you can't tackle them, you can't see a way out of them. But just to have the opportunity to brainstorm with other people that are going through the same sort of things, I mean, it's just really been able to bring some ideas to light and some solutions to things that, you know, we might not have thought of on our own. So I mean, that's part of it's been really, really positive for us as we move forward on this journey.
I think for Kat, for us, that would be one. Would you like to share with them about the physicians and your conversation about a big roadblock we've had here at St. Vincent is we have a large residency program, and how do we educate our residents on pediatric care and newborn assessment, but yet do assessments in the room. And so Kat met with one of physician partners at our collaborative meeting in May and had a conversation.
So I just sort of asked him, because he is their director of their pediatric residency program at a large hospital like ours, you know, how do the pediatricians have time to assess the babies in the room and teach the residents at the same time? And fortunately, he was able to share with us a form that he developed for the residents that sort of breaks down newborn assessment into various systems and helps them get the all the full assessment pieces, but in a different sort of way where it doesn't perhaps take as long in each individual patient room, therefore freeing the attending up to make sure the babies are assessed and moving along, and not spending huge amounts of time in each room where you're not getting all the babies seen and discharges are being held up and things like that. So that was tremendously helpful, and to be able to bring that information back and share it with our hospitalists was really positive, and they felt better. And there was lots of other ideas about things we might be able to use, perhaps carts that have supplies on it for the pediatricians. You know, we haven't exactly nailed down exactly how we're going to do it. I know we're going to put otoscopes and ophthalmoscopes in our patient rooms. We've looked at lighting in the patient rooms to make sure that it is adequate and comparable to the nursery, so that the physicians feel like they're going to be able to get an excellent exam done in the room. Feedback from parents is they like to see the pediatrician in the room. They have opportunity to ask any questions. We have computer charting in all of our rooms so that the physician can chart the newborn assessment immediately as it's being done. And that saves time as opposed to writing on paper and then going back and entering the data later. Those are some of the things that we've been able to do that are going to be really helpful to us long term.
So I think that's everything that we have to share at this point, and we'll turn it back over for questions.
Thank you so much for that, and we will now open it up for any questions that anyone may have. Anyone? I'm not seeing any questions. I'll wait a few more minutes just to make sure. All right, we have one right here. It says, how are you handling pacifier usage? Getting rid of them entirely or putting them on a Paxis, sign-out sheet, anything like that?
So we are not getting rid of pacifiers altogether. Pacifiers are used for painful procedures, which is allowable under baby-friendly guidelines. We are educating our families on delaying pacifier use in breastfeeding and encouraging, again, educating, documenting, and then ultimately honoring mother's choice on that component of it, but making sure that there is a documented conversation that mom has been educated on the delaying or not the non-use of pacifiers with a breastfeeding infant. We feel that it's important also that our bottle feeding babies understand through AAP recommendations that pacifier use is encouraged for putting that baby down to sleep. So we are not choosing to get rid of them completely. This was a conversation that was on our state phone call last week and talking about it with safety and AAP recommendations and those kind of components. And each organization is handling it a little bit different, but most we have found are not completely eliminating pacifiers.
The next question is, does your hospital have a certifier from WIC in the hospital?
Yes, we do. And you know what? That is someone that was at our first team meetings, and they are supportive, and we're working with them on our baby-friendly journey.
The next question is, how do you address tongue-tie issues?
Tongue-tie is covered by our physicians. Our lactation consultants can assess the situation and then relay the information that is seen to the physicians. We do have our newborn hospitalists will clip tongue ties if they feel that it's necessary. There is some reserve on whether that should be done in the hospital or delayed. There are some clear cuts that they feel yes. Other times they will ask to have that delayed until we can establish whether or not it's a supply issue, a maternal issue, is it a baby issue, and if it's a tongue tie, then we refer them to our ENTs.
The next question is, do hospitals have to do continuing education for their staff in order to maintain baby-friendly status?
Yes, there will be, I think it's up to our discretion, I believe 3 to 5 hours of education a year will be done once we reach the designation.
And once you have the designation, you're required to do some quality improvement ongoing projects so that they don't expect us to be 100%. They're looking for 80% compliance on most things when they walk in the door for the assessment. But if you have an area that you're weaker in, that would be one of the areas that you move forward with one of your quality improvement projects on. And we will be going through the designation process following the old criteria for baby-friendly designation. And as we move forward, our quality improvement projects will be centered, a lot of them around the new guidelines that just came out in 2016.
The next question is, how did your hospital allocate hours away from patient care to do this initiation?
So we really haven't allocated a lot of hours away from patient care to do it. The co-effective is online training, and the nursing staff will have opportunities during downtimes between patient care to complete their didactic requirements. The hands-on component we're still working through. Some of that will be through partnering to show skills, working with lactation one-on-one, going through skills fairs, and we budgeted for not a lot of additional. One lactation consultant is the baby-friendly team lead, Amy, and she has her 20 hours a week right now designated to going through some of the data. There's times where she's been in staffing, and there's times where she's really focused on quality improvement, data, mom surveys as we get into the dissemination phase with Baby Friendly USA. We expect that her 20 hours are really going to be spent in partnership with physician offices, doing staff education with the physician offices, and a lot with patients, making sure that we're doing what we say we're doing.
The next question is, what have you done about pediatricians that are resistant to getting formula out of their office from the drug rep?
So we educate on it. If it is a hospital-owned or hospital-affiliated practice, we have a little more leverage, and those are the ones that Baby Friendly USA is really going to be assessing and looking at. Your private pediatricians, it's about encouraging, educating, and asking them not to have those pieces and giveaways. But the private pediatricians, we don't have to move as much as our hospital. So our hospital owned and affiliated clinics are where we really are spending the most of our time.
Next we have, do you use ABM protocols for supplementation volumes, or does each pediatrician determine their own volumes?
Yeah, usually we refer to the baby's pediatrician to figure out how much the baby should be taking if the baby needs to be PC'd. Now I'm not sure what they follow.
The next question is, who does the initial vital signs on the newborn immediately after delivery? They ask if it's the L&D nurse or mother-to-baby nurse.
It's one of the labor and delivery nurses. Our hospital is set up where labor and delivery is on one floor and the mother-baby unit is on another floor. We typically have 2 RNs attend all the deliveries and 1 exclusively for the baby in case it needs to be resuscitated. And that is the person that would perform the initial steps of initial set of vital signs while the baby's skin to skin.
We just have a few more questions and we have some time left, so I'll finish up. Are your staff doing the cofective on their own versus someone teaching it to them?
This is online education. It's not using the platform to teach in a classroom setting. It is using the PowerPoint that they do self-directed didactic component with.
It's got pre-tests and then knowledge checks at the end of each section, and the sections really go through and focus on the 10 steps to baby-friendly designation. So by the time they're finished, they've worked through all the steps, and they've had we can feel confident that they have a good grasp of the didactic content, and then we further assess skills with the 5 hours of hands-on portion of the training.
The next one says, is there any way to get a copy of the slides? Which that's for me. Which yes, we will be posting the recording on the YouTube channel, so you can access that, and I believe the link will be on our website. Yes. Let's see. The next one is, do you have a breastfeeding orientation program for new employees?
So we've had a current breastfeeding education for new employees that all new employees within St. Vincent Women's Hospital go through 2 hours of education during new hire orientation for breastfeeding. We are going to be revamping that as we get our staff going with cofective training, and they're working through that. Our new hires will also all have to go through the cofective training, and it'll have to be complete within 6 months of hire to the organization. So with Baby Friendly, you have 6 months to get your staff educated to the Baby Friendly guidelines. We did choose to not accept outside Baby Friendly training. So if it's someone coming from another facility that was Baby Friendly, they will have to repeat the education for us, and we've decided that that cost was worth it for us to ensure that they are going to practice Baby Friendly the way that St. Vincent practices Baby Friendly and be held to the same level of competence as all of our other nurses.
And are lactation consultants on staff or readily available in baby-friendly hospitals?
Yes. We have lactation coverage here 7 days a week, ranging from 5 a.m. in the morning until 10:30 p.m. And generally we have 3 to 4 on staff at a time.
And someone asks, how can I apply in the WIC office? I want to collaborate with hospitals, going baby friendly, and want to reinforce what they educate at the hospital.
Can you read that question again? I'm sorry.
How can I apply in the WIC office? I want to collaborate with hospitals, going through baby friendly, and want to reinforce what they educate at the hospital.
I guess, I mean, if you want to like teach what we're teaching here, probably just, you could log into the, probably the Baby Friendly USA website and read over the, I don't know, what we,
Criteria.
Yeah. Or if it's Marion County WIC, you know, if we probably could get you that information, and so you could kind of see what we're teaching so that you can teach the same thing.
I also think that using the co-effective platform and some of the resources that are available from the co-effective platform would be a great resource for anyone working in WIC to work along in collaboration with any hospital that's baby friendly, or to help a mom meet her breastfeeding desires.
Yeah, another great resource is LER, the Lactation Education Resources. They have, if you go into the website, they have free downloadable, all baby-friendly approved handouts, several different languages too. So there's a lot available if you need information to give to patients.
That was the last question. I'll wait a few moments to see if we have any last-minute ones. Or you can read that if you want. The person who asked that last question says, I'm looking for all types of trainings, so I will check out LER in Marion County. Any other suggestions?
Yeah, the Carolina Global Breastfeeding Institute has some other information too. And I'm not sure if this person already works for WIC or is looking to work, or I'm not exactly sure what they're looking for, but you can always reach out to us here at St. Vincent. We'll answer questions. I think we really think that this is all about, you know, the community and getting, you know, everyone to kind of get on board with breastfeeding. So it's all a group effort. You don't need to reinvent the wheel.
All right, well, thank you to everyone who was able to listen today, and thank you to our wonderful speakers. We want to remind everyone about our next webinar, which will be held on October 18th, and will cover community snapshots and disparity in moms in prison. We hope that you enjoyed today's webinar, and we hope to see you soon. Thank you.